Hi everyone, welcome to the first episode of the Kenya Medical Association Young Doctors Network podcast titled The Health Front. My name is Dr. Christine Mutonyi. I am the convener for the Young Doctors Network. I'll hand over to my host.
Hi, good morning everyone. Greetings wherever you are. My name is Dr. Marie Claire Wangari. I'm the immediate past convener of the Young Doctors Network Committee at Kenya Medical Association.
Yes, so as I said, this is our first episode and we are super excited about this. And we have our first guest today, that is Dr. Daniel Ojuka. A round of applause. I think before we go into the introduction of Dr. Ojuka, and I think a lot of us know him, but before we do that, I'll ask everyone a question. Then you'll tell me the answer. So Dr. Ojuka's field is surgery, so the question is surgical. So what was the first surgical procedure, like documented surgical procedure to be done or to be invented? What was the first surgical procedure? Yeah, so any guesses?
I don't know, maybe laparotomy?
Not abdomen related, I can tell you that.
Not abdomen, okay.
Not abdomen, yes.
I don't know, maybe our guest might have an idea.
No, I think the oldest procedures would be, the first surgeons were barbers.
Mm.
So they were lancing abscesses.
Yeah.
So maybe abscess.
Mm-hmm.
Other than that, maybe amputation or removal of teeth. So I think those are the
procedures.
The earlier procedures. So yeah, you're pretty close. When you said barbers, it's like, yes, so it's on the head. So it's called trepanation. So it's
by the one we still do trepanation.
Yeah.
In Kenya, it's easy.
So it's basically drilling a hole into the skull. Yeah. So it was done as far back as 7,000 years ago. So in 2025, so like the 1300s. So it's the oldest known surgical procedure.
All right.
Yeah, so we learned something new today.
Yes. So trepanation.
Yeah.
All right. So if you didn't know trepanation, now you do.
Now you know.
And every day is a learning day. But besides what our forefather barbers used to do, today we have a very special guest, Dr. Daniel Ojuka, who is currently the Dean, Faculty of Health Sciences at the University of Nairobi. He is a breast and endocrine surgeon by training, passionate about medical education, and he has served in various roles before this one, including being the president of the Surgical Society of Kenya. So today we are just going to have a deep dive into surgery as a practice, medical education in the country, and what his views are on the same. So over to you, Dr. Christine, to kick us off.
Thank you. So first of all, huge congratulations on the new appointment. I didn't know, I learned today that you actually were voted in. So I don't know if it's a practice in other medical schools, but in UN, the dean is actually voted for by the other departments. So congratulations on winning the election.
Thank you.
So what motivated you to go into education? Like, why be an educator?
What motivated me to be an educator? So I think like I was just telling you before we started, I have worked in this country. I did my internship in Kakamega, Provincial General Hospital then. And during my undergraduate studies in third year, we did an elective in Garissa.
Okay.
At that point, there was only one medical officer in a provincial general hospital. And so after graduating, I felt that one of the things I needed to do in terms of giving back to the country, but also just to show gratitude to God for what He did to me, because I pretty much come from a very poor background, and I felt that if it were not from God, I wouldn't have been where I am even right now. And so part of giving back was to serve in Garissa, where there was only one doctor then. And so after finishing internship, I got married when I was an intern. My wife is a doctor as well. So we asked to be posted to Garissa.
Okay. You asked to be posted to Garissa?
Yes.
Okay, that's interesting.
That's a unique that's a unique perspective.
How many people would ask to be posted to Garissa right now?
I think that's a question we should ask our young doctors to comment on.
Yeah, just comment under the within the video how many of you would actually ask to be posted to Garissa, or basically out of Nairobi in the rural areas.
Yeah, so we asked to be posted to Garissa, the two of us. I think there's another colleague whom we were with in electives in Garissa from Moi then, Dr. Benjamin Odongo, who is a gynae now. And so we worked in Garissa with him for at least 2 years, and then we came back for postgraduate. My wife did obs-gyn, and I did surgery. So like I was saying earlier that I think at that point I really felt that the people in the rural Kenya were getting the wrong end in terms of access to healthcare. And so I was really interested in working in rural Kenya. One of the reasons why I did surgery was I felt that while internal medicine is a very important thing, I think as a medical student, I thought I was very sharp, so I needed to do internal medicine.
So how did you end up from internal medicine to the polar opposite?
Even in internship, I thought I should be an internist, you know. But when I went to Garissa, I think I felt that surgery would make a much better difference, because even as a surgeon, you still can see patients who have hypertension or whatever. And of course, we have our colleagues who can do that, but then you can oversee as a consultant. So I decided, I think surgery is this for me, so that I can give access to surgical services to people in the rural Kenya. And so by the time I was finishing postgraduate studies, I think there were a lot of issues in the northeastern part of Kenya. So we felt we needed to go to northwestern, not northeastern. So we went to northwestern Kenya, Kapenguria, to be specific, and served in Kapenguria for 5 years. So while serving there, of course, there are a number of people who are coming for after internship to be medical officers. Then I felt like they will come, report, call you back, say, I'm not coming. And so part of the reason why I came back to teach was how do I tell my younger colleagues in medical school that serving other human beings made in the image of God is an important thing in life. That's what makes us part of human in every sense. I mean, we can only show, I can only show you that I love you when I serve you. Not because you can give me anything, but because you are human. I serve you because you're human like me. Treat you with that equality. So that is part of the reason why I came back to teach.
Okay.
So part of what I saw when I came back as a teacher in the Department of Surgery is the issue to do with the professionalism and the way people learn to be professionals or ethical in their practice. Because if you go to a mission hospital like Tenwek, you will find that people go to work at 7 a.m.
Yeah.
They start doing round by 7 a.m. By 8, you pretty much, if you're a surgeon, you are going to the theater. You don't see that. And then after that, you go do your round as you go back to your... You pretty... It's a patient-focused, patient-centered service. And then if you come to what is in the public, I mean, so let's say it's non-mission private.
Yes.
Pretty much people do the same thing. Pretty much people do. Almost, maybe not exactly, but same thing. But if you come to public, we have this idea that we can come or not come at all sometimes. And so part of what I did for my PhD is how do we really learn to be professional? Where do we learn those kind of things? How can we make it better? So that is what really is still in my heart as now. How do we make professionalism? Because so long as you are in medical school, most likely, definitely, unless by reason of death, you certainly will become a doctor. I think the issue is what kind of doctor you will become.
That's true.
I think my problem then was the modeling part, which I don't think is still there yet. That we really don't model as teachers. We really don't model what it should be like. We pretty much rather the emphasis on private is seen by students that if you are a consultant, you pretty much want to do your private work than do public work. So I think people see that, and my thought has been, how do we change that? How do we make a difference? How do we model it differently? Because I don't think it's more of money. I think it is more of what we have been used to, what we have seen over time. And because we have seen it over time, we don't think there is an alternative to it somehow. And so looking for alternative in this context, I don't know what it will take. But yeah, so those are the... If you want to ask me what made me go to medical education, that would be it.
Yes, so you've mentioned one of the challenges about medical education apprenticeship, if I can put it like that, is that there is lack of, I think, the molding part in medical education period of your time is not as much as you get in your facility, and you're really left on your own devices. So maybe we could talk about a little bit more on the challenges that the medical education sector faces and what we could do to bridge those gaps. Because I think, to be honest, if you ask me in medical school, do I want to become a medical educator, it wouldn't be the top of my mind. But if you ask me if I want to become a surgeon, I'll probably say yes. And we always see it every KCPE, KCSE cycle, new cycle. You have someone who says they want to be a neurosurgeon, but I am yet to hear someone saying they want to become a medical educator. Yes.
I think the like right now there is a strike by WASU.
Yes.
Because there has always been that feeling by educators, whether medical or non-medical, that the government does not take educators seriously. And so the resources that are put there in terms of salaries and remuneration, that they are very, very low. Of course, like I was saying, the money really will never be enough.
That's true.
Because I think it's not that WASU people are wrong.
Yeah.
I think it is just that when I am going to work and you want me to concentrate on medical education, then I should be able to then take my children to the school that are appropriate, not necessarily high level, but I need to take my children to school and not borrow loan to educate my children. I should also then be able to get clothes that are appropriate and live in an appropriate setup. And I think that is the struggle that is in this country. And of course, given that we also do a lot of black tax, so when you are called a professor, everybody in your village think you should be earning at the level of the MP who has extra resources. I don't know how they get them, but yeah. So we have a lot of problem in our context, and I think what people are saying is that they should be able to live without struggling, and because of that, WASU will always be asking for more. So that is one aspect. The other aspect is for some reason, and it's not just medical education, I think it's education as a whole. As at now, I think there was a freezing in employment. I don't know whether that is true. I don't know whether it's just Ministry of Education. But I think the main problem is the expansion that the government, right from the time of Kibaki, started doing, of putting middle colleges to be universities. And you see the implication of that is that the resources that are meant for education that were probably for 10 universities are now going for 100 universities. And so the capitation for Nairobi, for example, was reduced from 800 million to 100 million.
And number of students.
No, more number of students.
More students.
And you have a capitation that has been reduced by 700 million, and you are in a situation where you want to pay your staff, so you have to look for money from maybe DSP or loan. Every month you want to do that. And it makes it difficult for the university to then manage themselves. And so you have a situation like University of Nairobi, where you only have one urologist. Actually, if there was no Kenyatta, University of Nairobi will find it very difficult to teach. Actually, some of the courses will actually collapse because in nursing, for example, there's no midwife teaching.
Just the KNH midwives.
Yeah, so if they were not there, there will be no nursing, because there's no nursing without a midwife. And so we are in very dire situation, as it were, in terms of educators, resources for education. If you go to Faculty of Health Sciences, you will realize that that medical education, those resources were designed for about 180, because when I was in school, we were 80. Probably the largest class would be 80. Yeah, I mean,
80.
for a class.
Oh, per class.
Per
okay.
class, 80 per class.
And us, we were close to 450.
450.
First year.
Each other.
Yeah. No, and us, the good thing is we were staying in the hostels.
In the hostel.
So we would know each other.
Yeah.
Them, majority of them were, I don't
Stay
even
outside.
think
They stay outside.
they know each other. So,
Yeah.
so those are, and you see that you have increased the number of students. You have not increased the number of faculty. And so the problem is the faculty to student ratio is just not within the remits of what even Q would require, which is a regulator. But you see, because it's a government institution, majority of time, nobody really puts his foot and say, we close you, go home. And so we have those limitations for public, and for medical education, it then becomes difficult. And so apart from undergraduate, of course, you have postgraduates that are also, I think what we did was we introduced MEd courses for all the specialties. And so we have, for surgery, we have 8. I think it's only medicine that are still very general, and pediatric. I think, and obs-gyn at MEd level, but the medicine is introducing fellowships. They are introducing those specialties at fellowship level, and I think pediatric as well, and obs-gyn as well. I think surgery then introduced those specialties at the level of MEd.
So you don't have to be a general surgeon to be a urologist.
You don't have to be a general surgeon to be a urologist, and you don't have to do general surgery and then now come for urology, or go outside for urology as it used to be before. And so because of those numbers, the optimal way of teaching becomes very difficult. Because you see, as a teacher, you are expected to be involved in research. Apart from teaching, you do research, create knowledge, and also offer services. Yeah, because you can't teach without offering services. As an apprenticeship thing, you only show people this is how you operate. They see you, they try with you, and they can try by themselves. So essentially doing 3 things: giving services, training, and doing research. But if your numbers are not optimal, majority of the time, what suffers is the research. Now, if you are in a situation where you feel overtime, and then the government does not employ new people, people who retire are not replaced, people who die are not replaced, then, of course, over time, people come to this sense of, I really don't have a future here. I mean, the future, there is no growth because you don't see younger people coming in. I am the dean, but I think I'm the youngest surgeon. I think it's only probably me and Kaisha. There are younger people in neurosurgery, younger than me, that were employed later. But for general surgery, I think we are among the youngest people. And so there are no new people who are coming, because you see, growth essentially means there are people who will retire, there are new people who are coming, so that the older people will show the newer people, this is how we work in this department. Otherwise, if you let everybody die and bring a whole new slot, people will even not understand how teaching is done. So that growth process in terms of educators essentially get lost. So, and therefore, even when you want to think about apprenticeship and showing
can't.
people,
Yeah.
it becomes very difficult.
Yeah, true.
Because you are one person, you are required to do, apart from the 3 things that I've told you, University of Nairobi is very essential for this country. So we participate in policy making. So you need to get time to do that. And then you also want, like, personally, I work with the technical working groups for breast cancer policy in terms of screening, treatment, and majority of other people do the same in their areas of specialty. And then now you are administrator. So you need to be in committees, even if you are not a chair. You are involved in committees. If you are chair, there are many more meetings. If you are dean, there are many more meetings. So you have like 5 things you're supposed to do. And yet, you're also supposed to teach. So that apprenticeship just get lost in the mix. And so I don't think that you really want to blame the teachers as of now, because the setup is not very optimal for them. I don't know how we will do that. Maybe God will do a miracle. The president said we are doing well. Maybe that wellness would be indicated, would trickle down to education.
But now, as a follow-up to that, some would say universities have put themselves in this situation by, first of all, enrolling more students than they can handle, and then also not ensuring, for example, the few faculty who are there are always show up. Because the fact is, sometimes the lecturers may not always show up for classes, or even if you wanted to be mentored as a student, you just don't have reach to the people who should be mentoring you. So then what would you say to that?
Yeah, so fortunately, I was at medical school. At medical school, I think we were 4th years when this parallel thing was being introduced. And so the introduction of the parallel was to do 2 things. One was, quote unquote, IGA for the university, in the sense that they will pay more, because I think Professor Kimani, the late Professor Kimani, the human anatomy professor, I think was very integral in introducing it. And his explanation, because we actually went to the streets, we said we don't think parallel is the way to go. But the explanation was that, these people go outside. I mean, their parents have money to take them outside anyway, right? And so some of them will go to some corridors in India and come back with a medical degree, whether you like it or not. So why not give a quality one here in Kenya and keep the money here and use that money, because even at that point, the universities were not getting the money they were getting, and use that money to therefore improve the infrastructure for the university. And I think after that, there were those UNES, university started university enterprise, and these people were paying money through UNES as an IGA to the university to improve. I think the only problem is we really didn't think about the implication in terms of, so we are increasing the numbers from 80 to 200. We needed to increase the number of teachers. We needed to think through, for the University of Nairobi, we have been using Kenyatta, and the infrastructure that is there is for that 80, 100 students. If you're going to do 200, which other facilities could we use in order to maintain the trainer-trainee ratio? because I think when we were rotating undergrads, we were 5 in a ward, right?
So if the teacher knew
So everyone was
We,
known.
if you miss,
You know.
you will be known
Yeah.
that you didn't go to class.
Yeah.
And you see, even your colleagues knew you.
Yeah.
So
Yeah.
right now, you have a situation where you have 20 students
Yes.
in one class.
In one class.
And there are 2 classes, so it means 40 students that are coming. That is MB6B.
Yeah.
So if you want to add MED over there, then you have a BBI type of siasa thing
Yeah.
in the ward.
Yeah.
It's a
It's a
rally.
rally.
BBI rally.
And it used to be like that.
Yeah.
It used to be like that. You're in a ward round and everyone is just struggling to hear the first one at the front because we are all so many
Yeah.
from undergrad to MEd. Yeah. So I know. as
And
a-
you see what
yeah.
then used to happen initially is say, oh, so and so, take the third years, go teach them
Yes.
in a corridor somewhere. But you
Yeah.
see, the moment you do that, you can only teach on one patient. The
Yes.
good thing about seeing the whole ward round is that you see very many
Yes,
pathologies. That's
pathologies.
number one. And number
Yeah.
2, you also see the continuity of care because you see
Yes.
what did we do to that? What did they say in this
Yeah.
patient this day? And then we lost that continuity and touch. And so you become more clever in the way things are supposed to be done, but you don't know really how they are supposed to be done. You don't know the practical thing. So the practical essence is removed from you. And so that happened. And so when you say the university took more students, I think they had an idea. They only did not then say, what is the implication? What do we do about it?
Yes.
They didn't probably think through that.
Yeah.
And then also, the government then said, okay, you can take care of yourself. We are reducing your capitation. And so that then meant you measure
You have to-
on the
Private students.
private student rather than on what is the quality that you are bringing out of this particular medical school or medical training for that matter. Because of course you see the other training, not that they're doing well, the other training, I mean, it's just class. So if you're doing business, economics, for example, while I think you still need to have a lot of discussion with your, and so the numbers I still think needs to be reduced if you ask me. But you see, there are situations, there are courses you can do like Zoom,
Yes.
1,000 people, they are okay. You can never do that with the
With medicine.
and so I think we kind of lost it there.
Can we come back?
I think we can, because number one, we probably need to reduce the numbers. Our thought in medical school right now is to reduce that number, the enrollment, to let's say because see the COOPS right now gives University of Nairobi around 180 students, and then we think that you should have either equal number of module 2 or less. Yeah.
So possibly a maximum
Of
you said 180
360.
so it's
360.
360
or 300.
or 300. Actually, our aim this last year was 350. But I think the only issue that you find is that there are a number of people who, for some reason, in year one, they get admitted, they come late, they don't learn well, so there's a number of issues in terms of people repeating year one, which is not a very good thing. And then, of course, the problem with every parent wanting their child to do medicine. And so there's a lot of push, like, oh, my child this, my child that. So you will find, as much as you want to reduce, if you're not able to withstand the pressure. So I think I think it is for us as the people in the leadership to then withstand that pressure from whatever quarter, because sometimes they come from very many quarters. We are in Kenya, you know. So they pressure you from every quarter. But I think it's just to say no. This is what we are planning to do. Start by reducing that number. I think the only problem is whether that will imply we go into more cash crises. And then secondly, look at how do you, because Faculty of Health Sciences, I think we have a lot of grants that we give to the university. I think is then probably think about how do you increase that grant portfolio and how that grant portfolio then can help in defraying some of those things. And then look at PPP models. Yes, so that you can have for infrastructure you can do PPP models, like for work with Kwetu, Kejani, for accommodation, so that even the people in parallel are nearer the school, and then you do that for postgraduates as well. To
hospital at night.
Because I think we lost that. The students are rarely coming to work at night. Think about digital classes, because we are in the digital era, so that we have, I think, our classes, and then you think about examination places, because if you go outside there, then you find places like clinical examination have studios for clinical examination, which we don't have. Then think about doing infrastructure for computers, classes for IT and medicine. Think about innovation,
Coding.
hubs, coding, all those things, innovations around medicine done by people who understand it, things like that. And then, of course, just helping renewal of passion for teaching medicine, because I think in a way, because of these problems, majority of public universities, faculty have lost that passion because of the things that we have undergone through those long history of, I don't know whether to call it neglect or just lack of what to do.
I think it's also important to keep people accountable.
I mean, in terms of keep people accountable, I personally believe it is easy to keep people accountable if, as a leader, you do your part. So if I'm supposed to give you salary, I give you your salary in time. If I'm supposed to give you an office, I give you that office. The infrastructure that are supposed to be there, you get that infrastructure. Then I can ask you, do your part. Do your part. Because you see, sometimes we ask people to do their part. I see it sometimes thrown outside there, that consultants work for 2 hours. I think you don't even understand. So what is the consultant supposed to do? Have they done it? So I am supposed to do this round in Kenyatta, and I have done my round for 4 hours. You start at 8, you end at 12 because you are teaching. Then you want me to sit in the ward. And then in Kenyatta, we are like 6 general surgeons. And those 6 general surgeons have 2 slots in a week to operate, Tuesday and Friday. So 3 surgeons for Friday, 3 surgeons for Tuesday. And you can only be 1 surgeon in the theater. So you can only operate maybe. So where do you want me to be? So before you blame somebody, I think you need to say, so what are you supposed to do? Have we given you the tools for that trade? Then I can ask, now do it. Yeah. So I cannot just say, you just do. You can't do things from the air.
Yeah.
I think we need to be fair for everyone. That if I'm going to demand accountability, that I've enabled you to do what you wanted to do, or you should do. Okay. And then I can say, now please do what you're supposed to do.
All right. You've highlighted a bit about the importance of using digital platforms, but right now the world is gradually focusing on artificial intelligence, and we're seeing it being used more and more each day, whether it's in reference materials or in training. There's, was it Albania that appointed a minister of AI? Yes, so we're even having now positions coming up because of AI. Yes, Minister of AI. So
interesting minister.
Yes. So my question is, as a medical educator, what do you think is the role of artificial intelligence, especially in the medical education training?
So you can look at it in 2 aspects. Number one, that AI is trained thing. It's artificial intelligence. So you need to train whatever it is you are using. They need to be trained. Yeah. And they need to be trained as per context. So that's one. So if whatever you want to do with AI, that AI needs to be trained for it.
Yes.
And then number 2, I think the doctor of the future would be a person who need to know how to use AI as an assistant. That AI can assist you because it's not going to replace you. So whether you think about AI and mammogram, because I am a breast surgeon.
Yes.
So the AI can aid the reading of the mammogram.
Okay.
It will not replace you.
Yes.
It will aid you in saying, these are not very complex things. Let the AI do.
Yes.
So that while, like where we are few, while I concentrate on the ones that needs to be done, by me.
Yes.
Okay.
There are things that AI will not do.
Yeah.
One of them is surgery.
Yes.
I think people think that robotic surgery means the robot operates.
Yes.
The robot does not operate. It's the human has to operate with the assistant. Well, I mean, it's like laparoscopy.
Yes.
Yeah, if the laparoscope doesn't operate, somebody uses it. So it's just that the surgeon may not necessarily be gowned, but they will be operating, the ones operating in the console. And so in the world of AI, as I see it in medical education, is to say, like, we have moved from the traditional training. If you look at medical education iterations, so there was a time where there's the mainly lecture. So I come and give a lecture. I am the one who knows. You guys don't know. I know. And then we move to problem-based learning, where we all contribute. The teacher comes as a tutor. You go read and then we come discuss. And then now we have flipped classroom, where the students come with the ideas that they have read everywhere. My role is to just help them say, think about it this way, because I have experience. Think about it this way. This is what happens in this particular context. Maybe that can happen in US, may not be happening in Europe, and maybe not happening in Africa. So that would be my role. So we have a flipped classroom. And I think AI has a role there for a flipped classroom. So where the student go do their researches, they learn, and then you come to the class to discuss with the teacher. And that's why I was telling you, even our infrastructure should mirror that. So we move from lecture halls to tutorial studios where you discuss issues, rather than a lecture hall where you come like tabula rasa. You're empty to be given the information. And so I think medical education elsewhere has moved on. I think it is us who are still, I think University of Nairobi is still very traditional in terms of lecture. I think Moi tried to move to problem-based learning, of course with this complication. I think Maseno is moving there. Because I was in a workshop where they were thinking about the logistics of introducing that with the help of Northwest University from Chicago. I think the other universities are thinking, I think it is probably for us in our next iteration of curriculum improvement that we think about that, and then think about students using AI. If you come to my round, I usually just tell the student, so you just ask your AI to tell you, so that we discuss. I mean, it's not that I know everything. It's you tell me what your AI is telling you. I tell you what should be, and that is how people learn from each other. I think the learning these days is changed to learning in the social context, that we all can contribute to that knowledge, and it's not the teacher that has all the knowledge.
Okay. Yeah. So at least it's reassuring to hear that you're progressive and you use AI in your rounds.
It can be.
Because the other thing is some lecturers, especially when you're giving students assignments, they'll be like, don't use AI. So
no, I think
we have to define
what need to be told to the student is that AI, if you ever use AI, please say I have used AI. That's number one, because we are being ethical. And then number two, just know that AI can give you wrong things. They, like I said, they need to be taught. And sometimes they guess. They hallucinate. So if you don't read whatever you're doing, you may be presenting hallucinations of AI. And people know how to, because if your normal English is not good and your assignment's English is superb, I will know you are. And then you see, for AI, unless you get the right tools to give you references, the references will be all hallucination. And so you need to be careful. We have seen it in students presenting their proposal. Because then you ask for DOI of whatever references, there will be no DOI. Because they are all hallucination. So AI is good, but I think it should be used as a tool that will aid you. So you have an idea, like me, if I have an idea and I want to make a speech, or I want to, like now, setting exams, you can actually just ask AI, I want this type of question. You give the right prompt, they will give you a question. The only thing is that you have to relook at it as the teacher. So I do best. If I ask a question and say, is this the right thing? Then you modify, right, according to what is evidence, because sometimes, like we said, they hallucinate. So I think AI should be used both at the teacher level and at the student level as an aid, not as the final tool you use. They will aid you so that you don't do the hard work. If you have an idea, they will aid you. If you don't have an idea, they will give you junk. Yes.
So then it means, some people have been saying that with AI now, for you to answer a single research question, you don't need to read 20 papers to get one sentence. Because before that was the case. If you're doing a research paper, you read 20 papers to do one sentence, 100 to do one paragraph. So does it mean we can't stop that? We still have to continue?
You see, you still have to say, is what AI saying what the paper is saying?
Yeah.
And so there are tools though that can help. There are people who have trained the AIs to maybe give you a summary. What should be emphasized though is that you must have the idea what those papers are saying. If you don't have an idea what those papers are saying, the AI can still mislead you. Because, like I said, you may never know the level of training of that particular AI tool with regard to those particular papers. So you may think it has summarized, and yet, if the person who is going to review understands those papers, they will tell you this is not in that paper. This is not what that paper is saying. And so you will be misled by the AI. And if the AI gives you papers, please go read those papers. Like I said, it's going to be a tool.
Yeah.
So over time, for example, I have been involved in the breast space.
Okay.
So I know what majority of researchers have found.
Yeah.
So if an AI summarizes for me, I would say this is out of place. This is so. If you don't know, you may not have the ability to say this is out of place. So you still need to do some work, except that it may not be the idea of reading those whole papers. So you can read 5, 6, 10, and if the idea is there, then you can say, yeah, the idea is there. Yeah.
Okay. So I know as when you finish school as a medical officer intern, or especially as an intern, there's a question you might get sometimes, rounds. It's which university did you go to?
And these days, people don't want to mention university.
These days, they're not training. They're not being trained. They're not training you the way they trained us.
Yeah.
Yes.
So, first of all, is that true? And second of all, what would you advise as a medical officer intern, or when you hear that statement from your senior? So what can
is
you
it
do
true
about
that they are not training the way they trained before? So in a way, like I was saying, because of the numbers, and that numbers, I know, for example, that Moi University also introduced parallel, and I think they did increase their class. If it is not in the second year, then it's the first year. I know they did. And so there is a way in which, because of those numbers, there is a way in which it is different because of the interaction with the teacher. So there's a way in which it's different. I think the teachers also whoever is in an internship center just need to deal with these interns with some grace, right? Because you need to know that is the context of our country, and it is not that the student decided to be taught in a different way to you. Is their time.
It's their time.
Yeah, is their time. And then secondly, I think we need to rethink internship centers as training centers. Because I think in our time, interns were not seen as students. They were seen as workers, right? That they will learn skills through work. So, but I think they need to be seen as a student. And thirdly, because we have increased in numbers and we don't necessarily need to increase, I think this is a controversial thing. Because my thinking as at now is that we need to find a way, because see, for us when we were trained, the internship was supposed to help you practice as in a way independent.
Yeah.
But I don't think we need to go that way necessarily because of the context where we are. I think we need to go to a place where, like US, your internship becomes your first year of residence, right? So that you don't have to do everything again. I mean, if you want to do OBSGYN, just start with OBSGYN. Your first year is your internship. And then if it is 4 years, you do 4 more years. And now you can practice as an independent person. So that would be my thought. And then we just strengthen maybe the current county hospitals.
Yeah.
And then we change the model of training from where now you have to go to university and pay them to a collegiate system where the hospital is the base of training. And so that when you go, like they do elsewhere, that we have training positions on those hospitals. And that, of course, that would just mean that you limit the number of people who can be trained in a year.
Yes.
Unless you're going as a supernumerary, which means you're not going to be paid. So you don't expect any pay. So in that way, we will now deal with the situation of numbers coming into one particular hospital like Kenyatta and expand that to county hospitals, level 5, level 4s, that they can be used for training and hence therefore expand the level of training. But the reality is that contexts have changed.
Yes.
We are not in the 1980s and 1990s. That has gone. I think we need to live in the current reality that we are in the 2025.
Yes.
And we have, instead of one medical school, we have 12.
Yes.
Or
Yes.
they have
When did they
medical
become
school. Yeah.
Yeah.
I left 9 and I was in school.
No, now they're
That's
about
3
12.
years ago.
Now
They
they're
may
about
be more.
12,
Because you
13.
have Pwani.
Yeah.
Yeah.
Aga Khan,
Aga
Masinde
Khan.
Muliro.
Yeah.
Yeah.
So, mhm.
Right.
So I think maybe
We-
as a parting shot,
Mhm.
someone wants to be a future Ojuka, a future educator in healthcare. So what would you advise them?
I would advise them to do what they do. When I say a calling, it doesn't mean you shouldn't be paid. But I think I believe that being a doctor is a calling, and being a medical educator is a calling.
It's a calling.
Because I have met colleagues who really have the call. I mean, they may not necessarily call it, say it's a call, but they have, if you think through what the university has taken them through, and they still are very passionate about training. You think about Professor Ruth Nduwati, for example, and Professor Mayo, Dr. Mary Beth, my colleagues that I know. I mean, even you think about a person like Professor Lukoya Tole. I think those are very passionate people about medical education that I know, that I have interacted with. So I think that passion is developed by seeing, more often than not, when you start training and seeing that what you do makes a difference. Right? Just like a doctor, you treat a child and you see the child smiling from when they have fever. That sense of that I am making a difference. I think it inspires. It inspires. So, and you see the being a doctor, you have opportunity, even when you are not designated as a teacher, including in Nyeri. So if you have interns who come for training and you see that just helping them know how to teach, make a difference in their life, I think it's an inspiration. So I think if you want to be a medical educator, you start small. Even at a resident level, even as a 6th year, if you teach I think I started teaching when I was second year. I was a demonstrator in anatomy. And we were demonstrating even to postgraduate students. So you see the smile in their face in getting the concept. And the idea. You just say, okay, this is what I want to do.
Yeah,
Yes.
I think that's true. I still remember my lecturer who taught me DKA,
Yes.
and the way he taught it is the way I remember it specifically, because he made it so simple and so like applicable. And I think that's essentially what you need in medical education.
Oh yeah.
Yes.
So
Alright.
allow us to just talk about one thing that we've seen in the news
Yes.
the last 2-3 weeks.
Okay.
Yes.
So what has your experience been with SHA?
Sure.
Yes.
Interesting.
Okay.
I don't know who designed SHA.
Okay.
I think he needs to ask for forgiveness. But
Yes.
but you there are two ways to look at it. Really. I personally think it was wrong to remove NHIF. That if you thought you needed to tweak a few things, you could have tweaked it right. I mean, using NHIF and maybe introduce legislation that shapes whatever how you want it shapes. I think the problem with SHA is that the way it was designed, like somebody was saying, I mean, I think it was designed to fail from the word go. It has, the problem is the government wanted it to work, and in a way, occasionally it does work for people. And so if you have a situation where sometimes it works and sometimes it doesn't work, what then happens is the people who say it doesn't work, maybe people may think they're against the government. I don't think there's anybody who's against the government. Everybody wants SHA to work.
Yes.
It's just that it's difficult because you see, for example, what they are doing as a surgeon, that you need to write notes after surgery.
Yeah.
And I don't know who
And
even
that's
going to
data
evaluate
protection.
who is going to evaluate those notes. And first
Yeah.
of all, even if you just leave the data protection alone, it's ridiculous to say somebody is going to sit and decide these notes were not written well, so I'm not paying you. It's ridiculous because you don't even know what was
done.
What was done. You don't
Yes.
understand.
You're
Yeah.
not
Right?
a surgeon.
You are not a surgeon. And even
Yeah.
if you are a surgeon, you are not there.
You aren't
Yeah,
there.
so you don't understand what I was doing.
Yeah.
So I think we want to use data as a point of correcting immoral or moral deficiency, and it can't happen. If people are fraudulent, they will write for you the best notes.
Yes.
Right? If the note is what you want, I will ask AI to write for me the best notes,
That's true.
even if I don't know.
Yeah.
And then you will say how wonderful these
The
people
facilities.
are. So I think let's not use data to deal with our moral deficiencies as a nation. Let's just say we are morally deficient, and how do we deal with it? And then, of course, then you bring the issues of data protection, and then you just realize we have a problem. SHA has issues. I mean, my friend who is, I don't want to mention names, but I have friends that I have called. They are very senior people, but I have called them and say, I have a patient in the ward. That patient is not being discharged because they have a problem with SHA. So I think the SHA issue, I think the government need not defend themselves. They need to listen. They need to listen to say, okay, you're saying there are challenges. What are these particular challenges? and then set out to rectify those challenges. Because, for example, it is not right to say that people have claims of billions and then you give them a portion of that billion, and then you did not write notes, you did not do whatever. I think while we want accountability in the usage of SHA, I think there are better ways. There are better ways of making people accountable, but also ensuring that if a patient was given a service, the level of notes written does not really nullify the service that was given. So you shouldn't deny the hospital money because they didn't write notes the way you want or in the manner in which you want. So I think we still have challenges as a country. Hopefully that the Ministry of Health, though they seem to be defensive about it, that they will be listening to people and that they will seek to rectify it. Because I think all of us want SHA to work. Because we all want everyone, including ourselves, to have access to the services that are being offered. And then, of course, we avoid these issues of favoritism in ways of these hospitals are paid, these other hospitals are not paid. I think we just need to be straightforward with every facility that offers services, and not necessarily favor for whatever reason, whether they know somebody or they're in my locality. I don't think we need to go that way. It is not going to happen.
All right.
We come to
the end of our conversation.
Yeah.
Yes, so we have had Dr. Daniel Ojuka, the current Dean Faculty of Health Sciences at the University of Nairobi, and we've discussed a myriad of issues. Right now, we've just discussed his views on the Social Health Authority, or SHA. We've also discussed the current landscape of medical education, the future of medical education, and advice to our fellow junior doctors and interns on how to have a career in medical education and surgery. So from our end, we'd like to say thank you very much. Until the next conversation.
Thank you. And remember, you can join the Young Doctors Network. Just email us at ydn@kma.co.ke. And remember to like, subscribe, and comment. Thank you.
Thank you.